You are welcome to this section. We will be discussing abnormal uterine bleeding. I'm Dr. Olayemi Olani Joseph, a senior registrar in the Department of Obstetrics and Gynecology, Obafemi Awolowo University Teaching Hospital, Ile-Ife. Looking at abnormal uterine bleeding, it's quite common in our environment, and it's one of the indications for referral to the gynecological clinic. In fact, 3 out of 10 women will come to the clinic with an abnormal uterine bleeding. At the end of this session, you should be able to recognize abnormal uterine bleeding in women of reproductive age group, to recognize patterns of bleeding, presentation of abnormal uterine bleeding, and to recognize presentations of abnormal uterine bleeding from normal menstrual bleeding, and to recognize complications that could ensue from abnormal uterine bleeding, and to be familiar with the treatment options of an abnormal uterine bleeding. By way of introduction, a revised terminology system for an abnormal uterine bleeding in non-gravid reproductive age women was introduced by International Federation of Gynecologists and Obstetricians, FIGO, in the year 2011, and this was the result of an international consensus process with the goal of avoiding poorly defined or confusing terms previously used. And this includes the menorrhagia, when a woman has excess of menstrual flow of more than 80 minutes, menometrorrhagia, when a woman has intermenstrual bleeding, and oligomenorrhea, when there is increase in the interval of menstrual cycle of more than 35 days. By definition, abnormal uterine bleeding is the bleeding from the uterus that differs in frequency, regularity, duration, or amount from normal uterine bleeding in the absence of pregnancy. This is actually the new definition that is used to define an abnormal uterine bleeding. However, there is an old definition, which is an abnormal menstrual bleeding and bleeding due to other causes such as pregnancy, systemic disease, or cancer. And there are, as I've said, there are some old terminologies that are used, and there are acceptable new terminologies that are used now for abnormal uterine bleeding. For example, before menorrhagia, which is excessive menstrual flow, is now being regarded as a heavy menstrual bleeding, and also a dysfunctional uterine bleeding, which is being used in the past, but is now being defined as is now being taken as bleeding of endometrial origin. An abnormal uterine bleeding could be acute and chronic. Acute abnormal uterine bleeding is an episode of bleeding in a woman of reproductive age who is not pregnant that is sufficient quantity to require immediate intervention to prevent further blood loss. While chronic abnormal uterine bleeding is bleeding from the uterus that is abnormal in duration, volume, and of frequency, that has been present for the majority of the last 6 months. This is the bleeding that has lasted for more than 6 months, and it's an abnormal bleeding from the uterine corpus that is abnormal in duration, volume, and of frequency. The history of an abnormal uterine bleeding has been confounding medical practitioners from the time past. And the earliest account was that of a woman with 12 years EU of blood in the Bible, that is taken from the book of Luke 8, chapter 43 to 44. And a woman having an issue of blood 12 years, which has spent all her living upon physicians, neither could be held of any, came behind him and touched the border of his garments, and immediately her issue of blood stanched. What am I trying to say? That it has been abnormal uterine bleeding has been existing before, and it has been confounding medical practitioner from the time past. First, the incidence of abnormal uterine bleeding, it is the commonest presenting symptoms and major gynecological problem responsible for as many as 1/3 of all outpatient gynecological visits, and it affects 30 to 30% of women in their reproductive years, and it accounts for 50% in perimenopausal women. The burden of abnormal uterine bleeding, it is a debilitating disorder both medically and socially, and in addition, it is the commonest cause of iron deficiency in the developed world, of which Nigeria is part of, and of chronic illness in the developing world. The number of menses experienced by women in their lifetime increases as a result of the reduction of the family size, leading to shorter period of childbearing and lactational amenorrhea. As a consequence of this, abnormal menstruation is especially a problem of the 28th century. I would like to talk about the normal menstrual cycle. What's happened in a normal menstrual cycle that would lead to a normal flow, and what will happen in an abnormal uterine bleeding that will actually deviate from the normal menstrual flow. In the normal menstrual cycle, it is the orderly cyclic hormone production and parallel proliferation of uterine lining in preparation of implantation of the embryo, provided there is a pregnancy. And in a normal menstrual cycle, the blood loss should be less than 80 mils, between 20 to 80 mils. Then the duration of flow should be between 2 to 7 days, while the cycle length should be between 21 to 35 days, average of 28 days. So any deviation from this could actually be a cause of an abnormal uterine bleeding. And in a normal menstrual cycle, it has been divided into phases. We have the follicular phase, followed by the ovulation, and there is luteal phase, and there is menses, following the luteal phase. In the follicular phase, which occur from the onset of menses to about 14 days of the menstrual cycle, when the LH surge is going to happen, which will be responsible for ovulation to occur. And the follicular phase, it could varies, and it is when the dominant follicles at the beginning of the menstrual cycle, there is recruitment of follicles that will continue to develop, and out of these follicles, a dominant follicles is going to be a dominant follicle at the end of the day will be the one that will be ovulated. And during the follicular phase, there's greatest number of granulosal cell and follicular stimulating hormone receptor, because there is recruitment of follicles, and they need to develop for ovulation to occur. After the follicular phase, then ovulation will occur, which is about 30 to 36 hours after the luteinizing hormone surge. The luteal phase, otherwise known as the secretive phase, is after the ovulation has occurred, and this is constant. It is 14 days, and it is during this phase that we have the effect of progesterone being predominant. And during this phase, there will be abdominal bloating, fluid retention, mood and appetite changes. And the pathophysiology of an abnormal uterine bleeding. Patients with abnormal uterine bleeding have lost the cyclic endometrial stimulation that arises from the ovulatory cycles, because it is during the menstrual cycles there are different hormones, the progesterone, the estrogen that are actually at play during this menstrual cycle. So when a patient has lost the cyclic endometrial stimulation from these hormones, that is when an abnormal uterine bleeding is going to arise. As a result, these patients, they have constant non-cyclic estrogen levels that stimulate endometrial growth. Estrogen is meant to result in the growth of the endometrium, and in a patient that has an abnormal uterine bleeding, there is a constant non-cyclic estrogen level that is making the endometrium to grow, and there is proliferation without periodic shedding, causes the endometrium to outgrow its blood supply. Because there is no shedding, there will be proliferation without periodic shedding, causes the endometrium to outgrow its blood supply, after which there will be tissue breaks down and sloughs off from the inside the uterus, known as the breakthrough bleeding, which will come out as bleeding, which is responsible for the abnormal uterine bleeding. And after this, there is subsequent healing of the endometrium, which is normally irregular and discontinuous in a patient with abnormal uterine bleeding. And there could be chronic stimulation by low level of estrogen, which will result in infrequent and light abnormal uterine bleeding. And there could be chronic stimulation from higher level of estrogen, which will lead to episodes of frequent heavy bleeding. What are the etiological causes of an abnormal uterine bleeding? Could be primary, secondary, or iatrogenic. I've tried to divide them to the causes that will occur in a woman during the reproductive age group, and in a woman that are perimenopausal, and in a woman that are post-menopausal. In the woman of reproductive age group, the causes include pregnancy, endocrine disorders, polyps, fibroid adenomyosis, coagulation disorders, and anovulatory disorders or anovulation. In a woman who is perimenopausal, the causes could be from cancers, from polyp, fibroid, or adenomyosis, and could also be anovulatory, which is leading to an unopposed estrogen and hyperplasia. Then in a woman who is postmenopausal, one of the causes is the atrophic vaginitis, which is the commonest cause of abnormal uterine bleeding in postmenopausal women. Others include cancer, polyp, estrogen therapy. To classify the causes of an abnormal uterine bleeding, International Federation of Gynecologists and Obstetricians in June 7, 2011 approved a new classification system known as the PAM-COHIN for the causes of an abnormal uterine bleeding in non-gravid women of reproductive age group. And the acronym has been divided into PAM, P-A-L-M, and this is condition that result from structural causes, while COHEI, C-O-E-I, is as a result condition that results from non-structural abnormality, and finally the N is not yet classified. So the P is the acronym for polyp, The A for acronym for adenomyosis, the L is acronym for leiomyoma, and the M is the acronym for malignancy. And while the C is an acronym for coagulopathy, the O is the acronym for ovulatory dysfunction, the E is an acronym for endometrial, while I is an acronym for iatrogenic, while the N is not yet classified. So the causes of an abnormal uterine bleeding can actually be classified and using the acronym PAL-COHIN. So how the causes, how would they present for a woman to recognize that she's having an abnormal uterine bleeding? The first one, polyp. They could present with symptoms of prolonged, uncontrolled bleeding. They could also present with intermenstrual bleeding, bleeding in between menstruation. And for a patient that has a polyp, the signs that could be picked on examination, the uterus is usually normal in size. If big, the cervical os may be patulous, and the polyp might be seen extruding outside the cervix. Those are the signs that can actually be seen with a patient that has polyps. And adenomyosis, they could present with heavy menstrual bleeding, and they could present with marked dysmenorrhea. While the signs that could be picked, the uterus is enlarged, could be up to 12 weeks enlarged, and maybe globular, and may or may not be tender. Then how a patient that has leiomyomata, uterine fibroid, how would they present? If is submucous, there could be prolonged uncontrolled bleeding, and there could be a heavy menstrual bleeding. And if it's subserous, the patient may be asymptomatic. And on examination, the sign, the uterus might be irregularly enlarged and firm. How will a patient that has a malignancy as a cause of abnormal uterine bleeding present? They could present with postmenopausal bleeding, and the bleeding is irregular, and on examination, there might be normal to mildly enlarged uterus, and the mobility may be restricted. The mobility of the uterus may be restricted. Then coagulopathy, a patient that has coagulopathy as a cause of an abnormal uterine bleeding, at puberty, they may experience menorrhagia. There could be heavy bleeding at menarche when they are starting their menstruation. There could be heavy bleeding, and there could be history suggestive of bleeding diastasis or family history of bleeding disorders. Ovulatory dysfunction, as one of the cause of abnormal uterine bleeding, there will be signs of anovulation, which can be seen in the patients with polycystic ovary syndrome, and they could also present with oligomenorrhea signs. They could present with oligomenorrhea, and they could also present with signs of insulin resistance. And on examination, the uterus could be normal in size. Then endometrial cause, as a cause of an abnormal uterine bleeding, they could present with intermenstrual spotting or prolonged spotting. And on examination, there will be discharge per vaginum, or there can be cervical erosion. Then iatrogenic causes, as a cause of an abnormal uterine bleeding, there can be history of medication use or medication intake, and there can be history of copper T use as a form of contraception being the cause of the abnormal uterine bleeding. And on examination, no abnormality may be found, and the uterus may be normal in size, and the copper T will be in situ. How do we evaluate a patient that has an abnormal uterine bleeding? Initial evaluation is germane, is key in the management of this patient. In a patient with a complaint of possible uterine bleeding, several questions must be answered initially to confirm the pregnancy status, the reproductive status, and the source of this bleeding. This will guide in the evaluation, the differential diagnosis, and disposition of the patient. So a good history is good in the management of this patient. One needs to take a very good history, and this will include the history of the onset of the bleeding, the quantity of the bleeding. Is it heavy? Is it spotting? Then is it intermittent bleeding? And the duration of the bleeding also needs to be noted. Also, are there associated symptoms like pain, abdominal pain, dysmenorrhea? Is there associated clots, the frequency of the flowing, and also is there association of dizziness, fainting attacks, which could actually tell us the severity of this bleeding. Also, one needs to ask for associated history like fever, chills and rigor, fever, also changes in the hair and body that could suggest one of the causes of abnormal uterine bleeding, which is the polycystic ovarian syndrome. And also, is there a history of nausea and vomiting. And also, one needs to take the gynae and obstetric history of this patient. The gynae history would include the menstrual pattern. Then, is the patient on contraceptives, and also past gynecological history also is important. Also, obstetric history of this patient also is important in the history taking. Family history also is important. Is anyone else in the family that is having an abdominal uterine bleeding? Is there any family history of von Willebrand disease, which could be a cause, or is there family history of polycystic ovarian syndrome? Then one needs to take history about the lifestyle of this patient, the nutrition, is the patient doing exercise? Is she on any form of nutrition? Are there weight changes? Then the exercise habits that the patient has been involved in, and also diet. Also one is to take the history of a diet that could predispose to an abnormal uterine bleeding. Then past medical history is important. Any past history of liver disease, kidney disease, anemia, drugs and medication. For example, is the patient on anticoagulant, blood thinner that could make her to have an abdominal uterine bleeding? And also, are there any history of thyroid disorders also? Then after taking a good history, a physical examination is important to examine the patient and look for signs of systemic illness that could suggest the cause of an abnormal uterine bleeding. And these signs of systemic illness include fever, ecchymosis, and enlarged thyroid gland, which could lead to a thyroid dysfunction, or evidence of hyperandrogenism, which includes hirsutism, acne, clitorimegaly, or male pattern badling, which is normally seen in patients with polycystic ovarian syndrome. Also, one needs to check the breast for galacturia, which could suggest the presence of hyperprolactinemia. After physical examination, a detailed abdominal and pelvic examination needs to be done for these patients. After examining, laboratory investigations needs to be done, and this includes pregnancy test, full blood count and platelets, clotting profile, hormonal assay. It needs to be done for these patients. Then imaging as a form of investigation is germane to the management of patients with abnormal uterine bleeding. Ultrasound is mandatory in abnormal uterine bleeding to evaluate the uterus, the adnexia, and the endometrial thickness. And Doppler ultrasonography is useful in suspected cases of arteriovenous malformation, malignancies, and to differentiate between fibroid and adenomyomas. Evaluation of the endometrium. How do we evaluate the endometrium for a patient that has an abdominal uterine bleeding? By doing a pregnancy test, endocervical biopsy. Also, hysteroscopy too could be useful to view the inside of the endometrial cavity. Transvaginal and abdominal ultrasound too could be used to evaluate the endometrium, and also saline sonohysteroscopy can also be used to view the endometrium. Also, evaluation of the uterus using transvaginal saline sonohysteroscopy, and also MRI can be used to evaluate the uterus. Taking sample from a patient that has an abdominal uterine bleeding by doing the histopathology is also important, especially for a patient that is above 40 years of age. Endometrial histopathology is recommended in abdominal uterine bleeding in women that is above 40 years of age. However, in women that is less than 40 years of age who have high risk factors for cancer of the endometrium, like risk factor that a family history of endometrial cancer, ovarian or colorectal cancer, or when the thickness is more than 12 millimeter, or patient has been on tamoxifen for hormone replacement and therapy, and such a patient needs to have histopathology done. Also, younger women, when medical treatment has failed, as I will still talk about in one of the management of abnormal uterine bleeding. Also, young women with risk factors for polycystic ovarian syndrome and obesity will also have histopathology done. And also all women prior to surgical intervention, which is one of the management that I will still shed light on, needs to have histopathology done for abdominal uterine bleeding. Endometrial aspiration should be the preferred procedure for obtaining endometrial sample for histopathology. And if endometrium is thick on imaging, hysteroscopy should be performed to rule out polyps in this kind of patient. And dilatation and curettage should not be the procedure of choice for endometrial assessment. However, vibra aspiration has been one of the methods of obtaining this endometrial aspiration for histopathology. The management of abnormal uterine bleeding, the treatment could be expectant or conservative, medical, and surgical. And surgical could be minimally invasive surgery or major surgery. The medical treatment that can be offered for an abnormal uterine bleeding includes the use of medication like progestin, combined oral contraceptive pills, and also the use of gonadotropin releasing hormone agonists, which I will still talk about. Also the use of iron and anti-fibrolytic agent like tranexamic acid can also be one of the medical management that can be used. Then the minimally invasive treatment that can be offered include the use of intrauterine devices with progesterone, like intrauterine system, Mirena can be used, and also the use of dilatation and curettage, endometrial ablation, uterine artery embolization. Then the major surgical method that can be used include the use of myomectomy for patients that have uterine fibroid, hysterectomy for patients who has complete their family size, and the hysterectomy could be by total abdominal hysterectomy or could be by vaginal hysterectomy, or could be laparoscopy assisted vaginal hysterectomy. Then I'll be taking the treatment option for each causes of the abdominal uterine bleeding from the acronym PAMCOHIN. For polyp, hysteroscopic polypectomy is recommended for younger women who wish to preserve fertility. Hysteroscopic polypectomy is the use of hysteroscopy to remove the polyp that is in the uterine cavity. And in women with multiple endometrial polyps that are not desirous to continue fertility, it is suggested to perform the hysteroscopic polypectomy, which will be followed by the use of an intrauterine system. For example, levonorgestrel intrauterine system can be inserted after the hysteroscopic polypectomy. And also for a patient that has abnormal uterine bleeding as a result of adenomyosis, and the women who are desirous of pregnancy, of preserving their fertility, but unwilling for immediate conception, could benefit from progestogen, from progestogens, especially levonorgestrel intrauterine system, could be recommended as the first line therapy. And for women who are desirous of preserving their fertility, who still want to give birth, and they are resistant to levonorgestrel intrauterine system, however, gonadotropin releasing hormone agonist can be added as the second line therapy for them. Then in the treatment of adenomyosis for patient that does not desirous of preserving their fertility, medical management using the gonadotropin releasing hormone agonist, and also combined oral contraceptive pills, danazol, non-steroidal anti-inflammatory drugs like mefenectinic acid can also be used. The treatment of abnormal uterine bleeding for a patient that has leiomyoma, uterine fibroid as the cause, should be individualized. Women with intramural or subserosal myoma who are still desirous of preventing their fertility can be managed with medical management with tranexamic acid or combined oral contraceptive pills, or the use of mefenamic acid as the second line management. However, women with intramural or subserosal myoma and desirous of preserving fertility will benefit from levonorgestrel intrauterine system if other medical treatment fails and the patient is not trying to conceive for at least 1 year. And also, if the myoma is causing infertility, mammectomy could be recommended for such a patient. For a patient that has abnormal uterine bleeding due to malignancy, endometrial biopsy will have been done for the patient to confirm the histopathology will have come back and confirm the malignancy, and the standard protocol for management of malignancy should be followed in such a patient. For a patient that has endometrial hyperplasia with atypia, hysterectomy is the standard treatment. However, for a patient that has endometrial hyperplasia without atypia, long levonorgestrel intrauterine system can be considered as the first line therapy for this kind of patient, while oral progestin can be also be used. In patients that has coagulopathy as the cause of the abnormal uterine bleeding, non-hormonal treatment with tranexamic acid as the primary option can be used for this kind of patient. Then hormonal treatment with combined oral contraceptive pills, levonorgestrel intrauterine system as the second option can be used. And also for patients with uncontrolled uterine bleeding in which combined oral contraceptives and levonorgestrel intrauterine system has failed, some specific factor replacements where possible, and also desmopressin can also be used for that kind of patient presenting with coagulopathy as a cause. Then in women not desiring conception, combined oral contraceptive pill can be used as the first line therapy for 6 to 12 months. And treatment of abnormal uterine bleeding as a result of ovulatory dysfunction, management could actually be by surgical intervention, and there is evidence of persistent abnormal uterine bleeding or failure of medical management to alleviate the condition. For a patient whose cause is iatrogenic, as in the cause could not be recognized, whenever possible, medication causing the abnormal uterine bleeding should be changed to other alternative. As I've said initially, it could be a medication, that the patient is on that is causing it. One needs to change the medication to other alternatives, and if no alternatives are available, levonorgestrel intrauterine system is recommended. For a patient that the cause cannot be defined, as in the patient has idiopathic as a cause of abnormal uterine bleeding, and in patients with abnormal uterine bleeding as a cause of in patients with abnormal uterine bleeding in which the cause is not identified, long-lasting the levonorgestrel intrauterine system are contraindicated, and use of combined oral contraceptive pills are recommended as the second-line therapy. The treatment for the management of abnormal uterine bleeding that are mainly cyclical or predictable in timing, non-hormonal options such as mefenamic acid, decanoic acid are recommended. And when medical or conservative surgical treatment such as endometrial ablation are failed or are contraindicated, however, gonadotropin-releasing hormone agonists along with added back hormone therapy are recommended to reduce idiopathic abnormal uterine bleeding, while hysterectomy is suggested as the last resort. Uterine artery embolization too can be used, is recommended for a patient with arteriovenous malformation. In conclusion, abnormal uterine bleeding is one of the most common problems in women of all age groups in reproductive period. It is a challenging and often confusing gynecological problem caused by various pathologies. Good history taking, clinical examination, and appropriate diagnostic investigation are carried out in the management of patients with abnormal uterine bleeding, and it is the main reason why women are referred to gynecologists and account for about 2/3 of all hysterectomies. Premenopausal women, abnormal uterine bleeding is diagnosed when there is substantial change in frequency, duration, or amount of bleeding during or between period. For postmenopausal women, any vaginal bleeding 1 year after cessation of menses is considered abnormal and require evaluation. Patients usually present first to their general practitioner, who can do most of the diagnostic workup and management. Specialist care is sought when the first-line medical treatment are failed or specialized testing is required. An approach to diagnosis and management of abnormal uterine bleeding in women of all ages is therefore important. Thank you. Okay. In conclusion, abnormal uterine bleeding is one of the most common problems in women of all age groups in reproductive period. It is a challenging and often confusing gynecological problem caused by various pathologies. Good history taking, clinical examination, and appropriate diagnostic investigation are crucial in the management of patients with abnormal uterine bleeding. Premenopausal women with abnormal uterine bleeding is diagnosed when there is a substantial change in frequency, duration, or amount of bleeding during or between periods. Postmenopausal women, any vaginal bleeding 1 year after cessation of menses is considered abnormal and required evaluation. Patients usually present first to their general practitioner, who do most of their diagnostic workup and management. Specialist care is sought when the first-line medical treatments have failed or specialized testing is required. An approach to the diagnosis and management of abnormal uterine bleeding in women of all age is therefore important. Thank you.